Welcome to Navicent Knows Health. I'm Cindy Busby, and I'm here today with Dr. Arnold Conforti. He is a general surgeon, but is fellowship trained in surgical oncology, and we're going to talk about his practice in Central Georgia. Dr. Conforti, thanks for being with me today.
You're welcome.
Could you tell our viewers a little bit about how your training is different than in general surgery? What does a surgical oncologist do?
Well, general surgery, when you have a general surgical training, it's usually 5 years of general surgery. And then if you wanted to do special training in surgical oncology, it's another usually 2 to 3 years extra of training. And there's several fellowships in surgical oncology, approved by the Board of Surgery, etc. So usually after the training, general surgery, you want to do surgical oncology, you do training in surgical oncology.
What are the areas of the body that a surgical oncologist works on?
Well, common cancers we would see, like for instance, breast cancer is common, colon cancer is commoner. Generally speaking, surgical oncologists do not take care of thoracic surgery. General surgical oncologists, I'd be a thoracic surgical oncologist or thoracic surgeon. So we see that quite a bit. Various types of GI tract cancers, or liver cancers, pancreas cancers, also skin cancers like melanoma. We see a lot of locally advanced skin cancers. And also there's a smattering of other things like sarcomas, which are soft tissue tumors you may see, but those are fairly rare. So the common things you're going to see more commonly, breast, colon, GI tract, etc.
When it comes to doing your particular kind of surgery, if you're taking out something like a tumor, where is it that the lymph nodes become involved in that when you're talking about cancer? What's the difference between if you were just having your gallbladder taken out versus if you're having a tumor taken out and it may have spread to other areas? Okay,
so basically, oftentimes, but not always, lymph nodes are important for staging of cancer. Sometimes they're important for removing the treatment of the cancer. Usually when you're taking out, say, colon cancer, you're supposed to get a certain number of lymph nodes, gastric cancer, a certain number of lymph nodes for accurate staging. But not all cancers is lymph node but spread important or significant. For instance, thyroid cancer, it doesn't really have any bearing on how people are going to do, and other tumors as well. So, but for the most part, it's important to get the lymph nodes for staging. Usually it's most important for staging. As I say, sometimes it's therapeutic as well, but mainly for diagnosis and prognosis, because then you can stratify patients into the correct stage to see if they need anything further done. So,
when it comes to working as a surgical oncologist, and we talk about a multidisciplinary team around cancer diagnosis, how do you work in that team, and who are the other members of the team for a patient?
Right. So the trend now is for most disease sites, you have a disease site team, so to speak, and that includes surgeons taking care of people, the nurses, radiation oncologists, medical oncologists, other ancillary people, for instance, the radiologist, sometimes other like rehab people, etc. And what you usually do is you want to present the cases prospectively, meaning before you treated them. You don't want to present them retrospectively, because you want to get everyone's input to make sure that we're following the guidelines and doing what we're supposed to be doing, because most times there's set guidelines as to how things should be managed, and you want to make sure you can keep things uniform for people, so although you treat everyone individually too. So
when when the pandemic started this year, what was the effect on the patients that you might have normally seen? Was there a detrimental effect to them, or could you continue to operate and see them routinely?
We pretty much, if someone had an issue with a malignancy or possible malignancy, we were seeing them as needed. Now sometimes people, I could think of, as a matter of fact, I just took care of someone today that they wanted to wait a little while. So like sometimes you can wait. For instance, if a patient has a breast cancer that's can be treated with hormonal therapy. Well, in the interim, while they're waiting, they could be put on the hormonal therapy. And then when things simmer down a little bit, that this person felt was sufficient with the COVID, then we do the surgery. So for the most part, we were working through it. Probably, you may not be seeing things, for instance, they weren't doing screening mammograms or maybe the colonoscopies, etc.
What have you experienced the use of virtual platforms in your practice since COVID?
Yes.
Are you able to do maybe pre and post-surgical visits, or how does that work with your practice?
Mainly the post-surgical, if you're giving them a pathology report, because pre-surgical, if you're before the surgery, you have to examine them, and it's tough to do that over, looking at them on the computer. So I tend not to do that pre-surgical, but post-operatively, that work came in handy. Give them the test results or something like that, or everything's stable, there's nothing, and they have no symptoms. So
why did you pick surgical oncology from all the specialties you could have pursued in medicine?
I just found that most interesting, and things are always evolving with it. Not that they're not evolving with other specialties, but I think now the main thing is that it isn't just one particular specialty or expertise taking care of a lot of these diseases. It's multiple, radiation oncology, medical oncology, surgery. So it isn't just one practice or one specialty taking care of them.
When it comes to a patient or a viewer who might recognize some of these conditions in themselves, how do patients get referred to your specialty?
It varies. For instance, most people, if they're getting their annual mammogram, for instance, or they find something, then their primary care doctor, whoever ordered the mammogram, will be sending them on to whoever they want. Sometimes we see them in the emergency room. They had a problem, they had some abdominal pain, or someone noticed they were losing weight, or something of that nature. Then they come to the emergency room, then you get referred them that way. Other people, for instance, they're seeing the dermatologist for a problem, and the dermatologist finds something else, or the thing they're being seen for is a skin cancer that needs some kind of surgical treatment. So for the most part, it's a specialty where you're going to have the patients sent to you from somewhere else. Not all the people are diagnosed. Sometimes we have to, do the diagnosing, but for the most part, it's being sent to you from another practice. So,
how important are diagnostics and technology to your practice?
Very important. All the imaging, the CAT scans, the MRIs, the PET scans, the mammograms, the ultrasounds. So all these testing, all these X-ray tests and testing is important for staging to determine if something you can operate on or you can't operate on, or they're on the fence and maybe they got to get chemotherapy first, then you can maybe restage them, see if you can operate on them after that. So it's very important to have a good imaging before you, I don't think there's any way you could do anything without having the imaging, really.
So, and last question, if a patient is coming to your office today, how has your office practice changed since COVID-19? What are we doing to make patients comfortable and feel safe that they can come back in and see you?
Well, first of all, there's no one in the waiting room. Yeah. They all have to have a mask. They all get temperature checks and things like that. One thing that's a little bit more difficult is they can't have anyone back there with them for the most part. So sometimes they may not be hearing everything or understanding everything. It's nice to have someone else there. I think that's the main things, and everything is getting wiped down, the rooms and all that, after they come and go. And
well, thanks so much for telling us more about your practice.
All right, you're welcome. Thank you.
And thank you for joining us at Navicent Knows Health. If you'd like to know more about Dr. Conforti and his surgical oncology practice, please visit us at navicenthealth.org.